We'll talk about management of end-stage COPD and management of dyspnea in this group of patients. So by definition, COPD, chronic obstructive pulmonary disease, is a chronic disease, and there is a airflow obstruction, and it is the result of combination of symptoms related to chronic bronchitis, emphysema, and also the asthma can cause COPD. But we're going to talk about mostly emphysema and the chronic bronchitis. As you all know, that it's a progressive disease. It's not curable, right? It's a chronic progressive illness, and it's a very costly disease to our system and also in other countries. Most of the cases are diagnosed at fifth decade or later in the United States. Patients with alpha-1 antiprotease deficiency are more prone to develop COPD, chronic inflammation in the lungs, especially the smokers. So we have in the United States we have 32 million cases, and like 2 million of the cases are related to emphysema, and 14 million chronic bronchitis. There is like 16 million patients undiagnosed, and total 32 million. It is the fourth common cause of death in the United States. Based on the calculation, it's projected as third by the year 2020. And we have every year 250,000 people dying of chronic obstructive pulmonary disease. And index admission mortality for COPD patients who are hospitalized with exacerbation, it's in between 2.5 to 12%. It may be higher for ICU admission based on the comorbidities too. Compared to patients who have cancer, COPD causes more incapacitating dyspnea and poor control. Based on the study, like there's one study I didn't put in the slide from Canada. They checked they surveyed the 118 hospitalized patients with advanced COPD, and based on the results, comparing to patients with metastatic cancer, COPD patients had lower satisfaction with the care, medical care, and experience more hopelessness, and the discussion of end-of-life care issues, CPR, were much less than cancer patients. It was an interesting study published in 2008. So if you look at the symptom burden in COPD patients, of course the symptoms are kind of different in patients with chronic bronchitis. Chronic bronchitis patients present with more like dyspnea, cyanosis, prolonged expiration, scattered crackles, rhonchi, most of the time. Cardiac dysrhythmias are common, productive cough with phlegm, peripheral edema, and increased anterior posterior diameter of their chest. If you look at the patients with emphysema, they have also dyspnea as like the most common symptom. They have barrel chest, use of accessory muscles are common, and they have decreased breathing sounds on auscultation, and you can hear wheezing. And they appear like pink and puffy, as you know from your medical school years and internal medicine. Anybody has like seen a lot of patients. So if you look at the pathophysiology of COPD, The destruction made by chronic bronchitis and emphysema is kind of a little different. In chronic bronchitis, there's chronic inflammation and destruction of the tissue. It's more like in the bronchioles and in those little tubes in the lungs. In emphysema, the damage is more like in the air sacs. And there's the constant dilation of the air sacs. And in many cases, both conditions coexist in each patient and various degrees and combination. So this is the chest X-ray of the patient with emphysema. You see the increased air. It's a very classic picture. So in COPD, there is a classification system. Majority of pulmonary physicians, they use GOLD's classification system. Stage 1 is mild COPD. FEV1 is, what is FEV1? Is right, forced expiration volume and per second. So it is, in mild cases, 80% or more of the predicted, and moderate COPD is between 50 and 80% of the predicted value. And stage 3 severe COPD, this is like what we see in our practice. The FEV1 is between 30 and 50% of the predicted. And the stage 4 is very severe COPD. We get this referrals for palliative care at this stage, if there's any. FEV1 is less than 30% of the predicted, and or it's less than 50% of the predicted plus chronic respiratory failure. The chronic respiratory failure, by definition, is based on the measurement of the partial oxygen pressure. SpO2 is less than 88%, and the CO2 levels are more than 50%. So how do you define end-stage COPD? It's very important for palliative care specialists to be able to define and concur with the referring attending or the referring physician that this patient has end-stage COPD. We need to know the disease first, right? So end-stage COPD refers to patients with GOLD stage 4, and patient has a severe airflow limitation, and there's a symptom of breathlessness, dyspnea with minimal exertion. So their functional status is very poor. Majority of them like homebound patients. They also have gas exchange abnormalities, the hypoxemia and hypercapnia, as I described before. And as you know, the quality of life in end-stage COPD patients is very poor, and this is reported. We know diminished mobility, deconditioning, poor exertional tolerance because of the disease, and they are dependent on most ADLs, and there's also social isolation issue. If you look at the patients with end-stage COPD, 41% of the patients who died of COPD had left the house less than once a month. So it defines their social isolation due to physical limitation. So quality of life is very important. We all talk about it. Based on the studies, there are multiple studies most done in Europe and Canada. Patients with GOLD stage 4 disease has demonstrated worse outcomes on the surveys. And this study was on large number of patients, and they used valid tools to check the quality of life, and it was very poor. As I mentioned, the Canadian study published in 2002 2008, comparing cancer patients and COPD patients and advanced COPD patients, show that these patients really suffer, and there is a heavy symptom burden that they deal with, and also the families suffer with them. Also, depression and anxiety is common. In one study, showed that in 109 patients with severe COPD, it was cross-sectional study, 57% of the patients showed the sign of severe depression. So when we treat these patients, especially during the final stage, these are very common and we come across. And you see panic disorder is 10 times higher than the general population in this group. Patients with COPD and anxiety have higher risk of exacerbations. So more hospitalizations, more poor coping skills comes with anxiety and panic disorder. So it is a challenge. Prognostication is in our toolbox as palliative care specialists. So how we prognosticate in this group? It's a very difficult group to make prognostication, and I'll tell you why. Prognosis in advanced COPD, this is like a study, like a subject for many research, and then since 1979, 1980s, and then recent studies show that the best predictor of prognosis is FEV1. So it's like testing patients for chronic obstructive pulmonary disease or asthma. You give albuterol bronchodilator, one dose, and then check FEV1 before and after. So if there's no change, what is that? Like if there's no change or minimal change, like no improvement, is COPD, right? In asthma, what would you expect after albuterol treatment? You expect that it will be like the FEV1 would improve, right? So this is 200 patients with COPD, and there was 15 years follow-up, and that's the outcome. In another study, they worked on follow-up 1,000 patients with mean post-bronchodilator FEV1 of 36%, and based on their finding that there was a 23% of mortality in 3 years if it is the FEV1 36% of the predicted value or less. There's another tool. This is used by pulmonary physicians, body index. Anybody knows? So body index is used for prognostication. It does include BMI, degree of airflow obstruction, dyspnea, and exercise capacity. So how you measure that? With a 6-minute walking test on a hallway, back and forth. So the parameters they use FEV1. So it has FEV1 is more than 64 and between 30 to 64. So goes on. 6-minute walk test. So it gives points, it's like 0.1.23. If patient walks like less than 150 meters in 6 minutes, is like 3 points. So higher points means like worse outcome. And then dyspnea index is used for dyspnea index 0 to 1, 2, 3, 4 to 5. So and BMI.
The 6-minute walk test, they have to walk without symptoms?
The walk test with or without symptoms, you stop patient, of course, and they become symptomatic. So they walk comfortably. If there's like little, dyspnea, but they're able to continue to walk, you let them walk. If it becomes like unbearable, you stop the test, right? So body mass index, cachexia is a very poor prognostic sign in COPD patients. So lower the BMI is the worst for this group. So dyspnea grading that mentioned in in those parameters, grade 1 is no dyspnea with a strenuous exercise like you and me. Grade 2 is like short of breath when you walking up a short hill. Grade 3 is dyspnea limits walking pace. They become symptomatic and then they have to stop and catch breath. And grade 4 is like they stop after walking 100 meters, which is 328 feet on a level ground, like it should be like hallway. And grade 5 is like dyspnea to the level that patient cannot leave house, and they have dyspnea with speaking, right? We know that. If you look at the Bode's index 7 to 10, which is the highest, and the months of the survival and probability of the survival. So even like the higher scores of like 7 to 10, 24 months, like 2-year survival, there's 2-year survival for 60 and 70% of the patients. So it remains difficult to predict, 6 months survival, because with the most sophisticated index we use, Bode index, 2 years survival with the higher scores like more than 50%. And how are you going to define 6 months survival if you are seeing very advanced COPD patients and you're thinking about referral to hospice, right? And you have to factor in other comorbidities and the frequency of hospitalization. In TORCH study, it is multi-center, double-blind, placebo-controlled study, and 6,000 patients were included. They had moderate to severe COPD. The patients who died during the study had faster decline in FEV1 and had increased hospitalizations and increased length of stay during those hospitalizations. I think when we see COPD patients and we are consulting, these are important factors and evidence-based to think about it and use in your prognostication. What happens like if there's a patient with a COPD, moderate level of COPD, and comes to hospital with acute respiratory failure because he had pneumonia? So what would be outcome? Like, do you think that this patient has high mortality? You would, right? In a study published in JAMA in 1995, the study showed that intubation, mechanical ventilation was not associated with increased inpatient mortality during that index hospitalization, or was not related to 1 year survival after that hospitalization, after patient intubated and extubated. So that really makes the prognostication difficult. So you have data that increase hospitalizations, decline in functional status, are the poor prognostic factors in COPD, and then you have studies show that even like ICU admission due to acute respiratory failure may not define poor prognosis. So it is really case-based. You have to use your own clinical skills and factor in comorbidities, and then do your evaluation case by case. Does having pulmonary hypertension affect the outcome? It's a cardiac, condition and can coexist in a patient with COPD easily, right? The right-sided heart failure and the pulmonary hypertension seen frequently. In our world, of course, since we see very advanced, form of this disease, we see the comorbidities very often present in same patient. So, COPD patients with a mean pulmonary artery pressure more than 25 showed 36% 5-year survival. So 36% was able to survive in another 5 years, but almost like 60% did not. So think about it in another way. COPD patients with normal right heart pressure showed 62% 5-year survival. So which one is the worst prognostic? Which one shows worse prognosis? The pulmonary hypertension patients, right? If patient has pulmonary hypertension and COPD exacerbation, frequent hospitalizations may have poor survival and then short life expectation. Let's talk about a little bit pharmacotherapy of the end-stage COPD, what we do use to treat their symptoms. It is actually not different than treating any other COPD exacerbation. We utilize bronchodilators, beta agonists, albuterol, levoalbuterol, short-acting anticholinergic medications like ipratropium, Atrovent, as like first line for dyspnea, breathlessness. Albuterol has rapid onset, but it is not the most effective medicine in COPD cases, especially in advanced stages. Anticholinergics, ipratropium, was more effective than albuterol in severe exacerbation and patients with COPD, unlike asthma, right? And if patient, if you look at the studies in advanced stages, a lot of patients cannot use inhalers effectively because their breathing is troubled. So nebulized delivery is more preferred, especially when they come into hospital. We switch them in our floor, right, to nebulizers. We don't use inhaler at all. Long-acting bronchodilators, they are like salmeterol, formoterol, long-acting anticholinergics, tiotropium are used and indicated in severe COPD, especially GOLD stage 3 and 4. They are part of their treatment regimen. Inhaled corticosteroids. Is it effective, you think? It is a second line and it's recommended as an addition to their regimen, stage 3 and above, for patients with frequent exacerbations. Based on the studies, for use of 18 months of the inhaled corticosteroids would lead to 1 fewer exacerbation for every 12 patients. So it does help with symptom control and can help patients to have less hospitalizations. So, as I said, most end-stage COPD patients cannot demonstrate effective delivery of inhaled drugs to small distal airways. That's why we use systemic steroids. What we use as systemic steroids is the methylprednisone, and you can also use dexamethasone in this group too. It's a long-acting form. We don't use systemic steroids for long term, as like other patients, it applies to other, COPD, asthma patients. We have to follow the same rules. It's not like patient with bone mets and we start the Decadron and stays on the Decadron for months and goes to hospice. So that has, even in those cases, it has no long-term benefit. So get used to prescribe the systemic steroids as like planned taper to stop regimens. You start high dose and go down. So long-term use of systemic steroids identified as a high risk factor for the mortality. So it does not, it may help with the symptoms for time being, but if you use it on a long time frame, it may not work for symptom control, and it may increase the mortality risk. And mucolytics like N-acetylcysteine, it is really not beneficial in COPD patients. We use with nebulizer, or it could be given through the through the trach. What is the side effect of N-acetylcysteine? When you administer N-acetylcysteine, what may happen? Bronchospasm is very common. That's why what we do? With albuterol, yes. So wiser, especially patients with heavy symptom burden, you don't want to risk. What is the place of oxygen supplemental oxygen in end-stage COPD? Is it beneficial or not? We know it's beneficial, right? Long-term oxygen therapy is indicated for patients who are hypoxemic at rest or with exertion. There is an old study, nocturnal oxygen therapy trial, compared to continuous oxygen therapy versus nocturnal oxygen in patients with COPD. They showed that significant survival benefit happens in patients with continuous oxygen supplemental therapy. So we don't hesitate to prescribe. The thing is, in Medicare, Medicaid patients and many HMOs require the documentation of hypoxemia. So without that, they don't pay for the oxygen therapy. So you have to document that patient has oxygen saturation less than 88% without oxygen therapy in room air. So this is again related to prescribing oxygen therapy, especially to Medicaid patients, Medicare patients. You can prescribe up to 99 months as lifetime if you document that patient has low hypoxemia in room air O2 set is less than 88% or 88%, and they will pay. In advanced COPD patients, it's another issue that can they benefit pulmonary rehabilitation? Can they get better if you force them to do to join the rehab and physical therapy? Based on the 2005 study in patients with GOLD stage 4, like end stage COPD disease, who were receiving pulmonary rehab, the 71% of patients had improved body index because the dyspnea was better controlled. So it's good, and we can prescribe. Even hospice patients can get physical therapy rehab to improve, to help with their dyspnea and functional status. There's another option to help these patients. Non-invasive ventilation is positive pressure, non-invasive positive pressure ventilation. It can be alternative to mechanical ventilation in very severe hospitalized patients. And patients should have acute hypercapnic respiratory failure. It does reduce mortality and the need for intubation, but at final days of life of patients who has end-stage COPD, none works, even like non-invasive ventilation. So what we use BiPAP, bi-level positive airway pressure. This is the device, and it has like full mask. There's also a different form of mask. It's just applied around the nose for patients who cannot tolerate this mask because it can give a feeling of suffocation, and they can't stand. I found that if patient becomes restless and trying to pull the mask, giving very low dose Haldol would help. It does not suppress the respiratory center, and patient may calm down and tolerate the machine and continuous airflow. And non-invasive ventilation used for severe stable COPD patients who has baseline hypercapnia as a palliative intervention. It can be prescribed. It does rest respiratory muscles and help with breathlessness feeling. Even with non-invasive ventilation, cancer patients, very advanced cancer patients with dyspnea demonstrated some relief. So we can prescribe it to Medicare patients. Medicare Part B pays. So you have to document CO2 levels more than 52, and of course end-stage COPD, and the oxygen, like the during the sleep, the oxygen desaturation is, again, SpO2 levels less than 88. There's another symptom that close to dyspnea, but it's different. Breathlessness. We have to mention it's really seen in end-stage cancer patients like lung cancer, end-stage COPD patients, especially very common in COPD patients. Based on the surveys and also in Canadian study, 98% of the patients died from a COPD had breathlessness in a level that it was so severe during their final days. And if you look at the survey results, it's their worst nightmare, fear. Like they are so fearful of breathlessness, feeling of suffocation. That's why even like patient with do not intubate order and advanced COPD comes to emergency room and says, do whatever you can do, like intubate me, right? So it's not unusual. So when we use opioids for dyspnea management, is it like first line or for dyspnea? It is not. You know, it is even like end-stage COPD patients, you have to provide mainstream approach first, right? You have to give albuterol, your Atrovent, ipratropium trials, oxygen. You could utilize fan to get like better feeling of airflow to their face. It helps. And when all fails, you can start to prescribe morphine. How do you prescribe to the morphine for dyspnea in opioid-naive patients? Like you have this fragile 76-year-old man comes, cachectic, comes with COPD exacerbation. You know, the other treatments are failing to help him with the dyspnea, and you want to prescribe morphine. How much you would prescribe the dose? It's like, you know, you could do 2 milligram. I start with 2. Some starts with 1. You know, 1 is to me is like a drop in the ocean. So you could do 2 milligram every 2 hours as needed, easily, and titrate. And in the cases, you know, requires very often morphine injection, you can easily start morphine drip if needed to be able to help.
The other part of that, I think, that kind of needs to go into the equation is the existential experience of the patient. So if you've used all those medicines and then you're going to start opioids, to try to build a success as quickly as you can, because while the patient is lying there and the family is, all that's going on. So I don't know exactly how that goes into the equation, but having been there when that is a symptom, it really is very good for patients and families to feel some sense of improvement in that symptom.
Right. In a case, in our settings, we transfer patients to our floor coming from ICUs or step-down units with severe dyspnea, already their own multiple medications and nebulizers, oxygen, and coming in for end-of-life care. We may even start drip right away, 1 milligram per hour, even opioid-naive patient, for the reasons that you mentioned. So communication with advanced COPD patients is troubled. A lot of physicians are not able to start these discussions. The pulmonary specialist may have like long-term relationship with the patient. It is difficult topic to approach. Based on the surveys, end-of-life care discussions occur only for 20% of the patients with advanced COPD. If you survey them separately, they say patients would say that we want to talk about it, but in the real life, it doesn't really go easy to start a discussion, because they may have improvement with hospitalizations, with interventions during this, advanced stage, fluctuations of the functional status. They are, you see the response, they are able to go back to their baseline, and eventually one of those hospitalization, unfortunately, patient may die. So physicians should be prepared to help patients to discuss end-of-life care, especially the issues around mechanical ventilation, non-invasive ventilation, the options available, and when the disease is very advanced stage, and we have obligation to tell them that at certain point, once they are intubated, it may not be possible to extubate them or wean them off the ventilator. At that point, many may opt for not being intubated because not all patients would want to spend final days hooked up on the machine. And the caregiver burden in this group of patients is common. It is unfortunately less understood in advanced COPD. Caregiver burden is studied, published in cancer patients extensively, but when it comes to advanced COPD, CHF patients, there's not much out there. Recent studies show that high symptom burden and suffering of both parties, the patient and the family. And the current approach still focuses on physical symptoms and disease management because the symptom burden is so heavy, and unfortunately you get just sucked into treating the symptoms, trying to achieve some improvement, and it may happen. It's not like cancer, end-stage cancer, they go into steep decline and then eventually pass away. As a palliative care clinician, we have obligation to kind of explore caregiver issues, the interaction between patient and the family, patient's feelings. A lot of them feels like they are a burden for family for a long time. It's a chronic progressive illness, as I said, and they are disabled patients, and we should be able to kind of try to find resources to help these patients. A lot of time, these families left to grapple with significant suffering. Terry, do you want to say anything about reaching out to families of patients with chronic advanced illness such as COPD?
One thing I would say also is that in an illness where you do have hospitalizations and then people recover and then you have more hospitalization, sometimes family do not understand the meaning of that progression, and they expect the same thing to happen over and over again, so they don't get that there may come a time where this hospitalization is not going to have the same effect. So because we're experts, and we need to help people with anticipatory guidance and understand that that may not continue. So that those ups and downs really confuse families sometimes because folks get better and then they go home. The other thing I think was really important is financial issues. As people are maintained in a chronic illness state for a long period of time and families can't go to work or they do go to work, and all of that the psychosocial aspects of what goes on around living with a chronic illness over time. And one other thing is teaching families how to act when somebody is short of breath. I think that we don't do a good job of that, and so that the panic that sometimes occurs in families is catching, and as long as we don't catch it, that's a good thing. But patients catch it, and it can be very cyclical. So the more that we can teach families how to calm their patient and calm themselves, the less their contribution will make things worse rather than better. And also, it's wonderful to teach our families how to relax and how to calm themselves down and how to listen to their own internal dialogue, because that helps them with their suffering as well.
What I found in these patients is that their families and patients suffer spiritually, existentially, especially in the patients where smoking is the primary cause of the disease. Families feel an enormous amount of guilt. I should have stopped him. I should have taken the spirits away. I should have helped him more. So they
In conclusion, COPD is a chronic progressive disease, and towards the end stages, stage 3 and 4, the symptom burden is high, and unfortunately resources for these patients are limited. Even like utilizing hospice is troublesome, because they require a lot of medical intervention to overcome those episodes, exacerbations. It may not happen in hospice world well, because of the more like opioid and like kind of there were court cases, patients managed under hospice. The family wanted more intervention, and they were just increasing the opioid to help with dyspnea, because that's only what they know. It can be annoying sometimes, because patient may have pneumonia, etc. There was one case that they kept increasing the morphine, and patient eventually passed away, and family asked for autopsy and showed bilateral pneumonia. And no physician has seen this patient, just a nurse kept increasing the narcotics by talking to a physician. So these are, to me, is not acceptable as a physician. But if patient is, not willing to go through any treatment once just end of life care, that may happen. But a lot of time it doesn't happen. So they look for a reason, and if it is treatable, they want treatment. So more needs to be done. Maybe CHF programs, like there are programs that follows these patients, chronic congestive heart failure patients at home. That kind of home care programs may be developed to be able to serve these patients. Meanwhile, we will continue to deal with the treatment of advanced stage COPD patients, and number is increasing, so new generation will be seeing more and more COPD patients, and I'm expecting that some improvement will take place in next decade when it comes to management of chronic illness, including COPD, CHF. Any question? Okay. Thank you.